All right, for this week's interesting case, I am going to talk about the castration that I helped with this week, and it was on a one-year-old stud colt, and for his pre-med, we used Pepgene, proparacaine, penicillin G. And then for his induction medications, we used ketamine and midazolam. And for his post-op meds, we did Banamine and Xylazine. And the process was the whole procedure was a lot easier than I ever thought it would be. I always hear about laying him down in the field and everything like that and just doing it there, but I just expected this more crazy type of situation than it actually was. The stud colt was also very naughty. He was a septic foal last year that they had seen, and after all of that, he has been babied ever since then, so he doesn't really have a whole lot of manners. So he doesn't like restraint. He doesn't like being told what to do at all. So it was a little bit of an adventure, but he was so small still that it was a lot easier to handle him than we thought it would be. And so we took him out to just the grass area that we have there at Comstock, just out on the lawn, and we gave him his pre-med and or his induction meds, and since he was so small, we gave it to him, gave him a minute, and he slowly just slunk down, and when he did, he goes down, and their front feet just kind of slide out in front of him, and then the rest of their body goes down, and then from that point, we can kind of push him, whether we want him right lateral, left lateral. In a castration situation, it does not matter. So we plopped him down, he was in right lateral, and as soon as we got him down, we had a long white rope, and the leg that is on top, we tie it up. So if this is the leg right here, we would wrap the rope all the way around it like this. So it's around the hoof and back around the hock. So if he were to wake up or feel anything and go to kick, that leg can't really stretch out too much, giving Doctor a chance to get away. And the reason why it gives her a chance is because Doctor is right between his two back legs doing the procedure. And so when she does the procedure, they did use a block, and I'm trying to remember which one it was. I can't remember exactly, just because it was kind of like okay, he's here, let's go do this. I wasn't able to grab paper or anything like that. And so we do use a testicular block. So we blocked each testicle, and then we blocked the kind of just like the midline of the scrotum. Doctor then makes an incision over both testicles, so there's two incisions, and she pops the testicles out of those two holes. And then what she does is she takes dry gauze and kind of pulls back all of that tissue covering so that the spermatocord and the muscle and everything are revealed and visible. At that point, she uses Reimer emasculators, and she slides that on there and gets them clamped to make sure that she has the testicle and she has the cord and the muscle all in there. And then she clamps down, and that cuts the testicle. And then she has a timer start for 1 minute to kind of help with clotting and everything like that at the end of that where the testicle was cut. While that timer is going, she is suturing the end of that spermatocord to tie it off. And then once the timer is done, she can take the emasculators off, finish suturing if she has not already, and then that's done. And then she repeats the same thing with the other testicle. And then what she does is she kind of cleans up as much blood as she can, because it is quite a bloody process. And then she makes sure that the cords have gone back into those incisions and back up where they need to be. And she cleans out all of the blood that has clotted, cleans everything out, and then she sits and waits and watches and looks through the skin to make sure that there's no bleeders, there's no flowing blood, and that she's not getting new blood or anything like that. She does leave it open. So those incisions will be open. So before we get them up and let them come to, we clean them up as best as possible so it's something easier for owner to monitor. And so got him all cleaned up that way, and that was good. We did put a catheter in him to push drugs or anything like that. So if he was making any noise, twitching, anything like that, we would push more drugs through a catheter. And we just used a little shorty 18 gauge catheter, so what we would use in maybe not an 18 gauge in small animal, but similar catheters to what we use for dogs and cats and things like that. Typically the catheters are very, very long catheters. And so once everything was done, we stopped pushing drugs and we basically just let him come to slowly and need be. And then once he's up, he's recovering, and post-op we monitor his incision. We were monitoring it every hour. And we would just go out and make sure that he was not continuously bleeding. Doctors like to monitor if they are bleeding, how many drops per second. If it's 2 drops per second or less, not a big deal because they will bleed. It is left open. There will be discharge. If there's a steady stream or if there's anything higher than 2 or 3 drops per minute, then doctor gets a little bit concerned and will monitor them a little bit more closely and kind of go from there and see if we need to lay them down and if there's a bleeder and have to kind of close anything off or cauterize anything. This stud colt did very well. He did not have any crazy bleeding or discharge post-op. And we tell owners to monitor for any major swelling or anything like that, or pus or infection that may or may not go on. As far as I know, he is still doing well. And what I did in that process is I was holding the rope to the back leg. So yes, we tie the hoof and the hock so they can't kick, but it needs to be out of doctor's way. So I held the rope, and it was nice because I had a really great view of what Dr. Copeland was doing in that procedure. And Lexi was handling the anesthesia part, monitoring him, taking his vitals, making sure that he was doing well. And there is another intern there in his 4th year vet school at Virginia Tech. And so he was basically watching Dr. Copeland, and she was explaining things to him and having him assist her, so he kind of understood the process a little bit better. In that process, he also had his wolf teeth, so Dr. Copeland went ahead and extracted those. They were still pretty small, so they were quite a hassle to get out of there. She said usually on a bigger stud colts that they're a lot easier to kind of dig around and then pop out. And the intern that was with us is more interested in small animal than large animal, so he was able to reach in there and he was able to pop that smaller wolf tooth out no problem. Like I said, the stud colt recovered great afterwards, and he went home that night or that afternoon. And that is all I have for my interesting case for the week.